Welcome to the Deep Dive. We are back, and today we're taking on one of the most common and honestly one of the most challenging complaints in medicine, dizziness. We're going to break down the clinical guidelines and get into the essential knowledge you need.
We are. We're moving beyond that vague subjective feeling of being dizzy and diving deep into the very systematic, very fascinating process of clinically assessing vertigo. We're going through the source material to focus on the key diagnostic differences, the comparisons that experts use to really pinpoint the cause.
And our mission today is simple, really. We want to give you a detailed, step-by-step look at the entire battery of tests that can turn a patient's complaint into a precise diagnosis.
That's right.
This is your shortcut to mastering the logic.
Right. From a simple mechanical issue all the way to, a potentially life-threatening neurological event. And we have to start with the cornerstone, the absolute foundation.
Which is the history.
It's always the history. Because the term dizziness covers so much ground, doesn't it? I mean, unsteadiness, lightheadedness, a feeling of faintness. So we have to immediately make a core distinction that's emphasized in all the guidelines.
And that is?
True rotatory vertigo. If a patient isn't describing an illusion of rotation, either the room is spinning around them or they feel like they're spinning inside the room, then it's not technically vertigo.
So they're experiencing something else. Disequilibrium, maybe?
Exactly. Disequilibrium, unsteadiness, pre-syncope. And those sensations usually point you toward cardiovascular, maybe neurological, or even musculoskeletal issues. For it to be true vertigo, you must have that distinct rotatory element. And just pinning that down is the very first diagnostic step.
That distinction is absolutely paramount because it immediately sends us down the vestibular pathway, right?
It does.
So once we've established that, yes, there's a spinning sensation, the history then pivots to what you call the timeline test, the longevity and frequency of the vertigo.
This part is non-negotiable. The timeline gives you immediate clues and often starts to differentiate a peripheral cause, something in the inner ear, from a central one in the brain. We basically classify symptoms into 4 major time brackets, and the differences are, well, they're extremely telling.
Okay, let's walk through them. Let's start with the shortest possible duration. If the vertigo only lasts for a few seconds at a time, what's the leading hypothesis?
An episode that lasts for seconds, especially if it's provoked by a specific head movement, that is overwhelmingly suggestive of benign paroxysmal positional vertigo, BPPV.
And the brevity is the key there.
The brevity is everything. The vertigo is caused by these tiny crystals, otoconia, that have become dislodged and are moving around in the semicircular canals. Once they stop moving and settle, the symptom stops immediately.
Okay, so moving up the scale. What if the episodes last longer, for several minutes, but not, say, a full hour?
Now that shifts the differential diagnosis quite a bit. That duration is just too long for the fleeting mechanical nature of BPPV, but it's also a bit too short for a major inflammatory event.
So what are we thinking then?
Minutes-long episodes suggest conditions like an early-stage Meniere's disease, or perhaps a vestibular migraine, or even a transient epileptic vertigo. In that time range, the pathology is often developing and resolving very quickly, maybe due to a temporary vascular spasm or some kind of transient fluid fluctuation in the inner ear.
Right. And if the symptoms are sustained for hours, a full-blown, incapacitating attack.
Now you're in the domain of a classic, fully developed Meniere's disease attack. That's where you have endolymphatic hydrops causing sustained pressure in the inner ear, or, alternatively, a very significant severe vestibular migraine.
I see. So for that duration, you really have to start looking at the associated symptoms to tell the two apart.
You absolutely do. You need to compare the otological symptoms, hearing loss, tinnitus, against the neurological ones like headache or photophobia.
Okay. And finally, the most alarming one, an acute single episode that goes on for days or even weeks.
That is the ultimate red flag. This kind of single sustained attack strongly suggests an acute destructive lesion. We're comparing things like vestibular neuronitis, a viral inflammation of the nerve, or labyrinthitis, which also involves hearing loss,
Against the biggest concern.
against the most critical central concern, a brainstem stroke, particularly a stroke involving the posterior inferior cerebellar artery, or PICA. The sustained, severe nature of the vertigo means the system has been functionally knocked out, and it's going to take days for the brain's central compensation to even begin to kick in. The timeline alone is a powerful triage tool.
That systematic classification by time is incredibly useful. So beyond the timeline, the next step is looking at specific triggers, what actually brings on the symptoms. This is another area rich with comparisons.
It is, yeah. We ask simple questions that can have very complex answers. For instance, if the symptoms kick in when you stand up, we're probably focused on postural hypotension. a cardiovascular issue.
Right.
But if the dizziness happens specifically when turning the head quickly, we suspect BPPV or maybe a general peripheral vestibular hypofunction where the vestibulo-ocular reflex just can't keep up.
And the source material gets into some really specialized, almost mechanical triggers,
Yeah.
particularly this connection between sound and balance.
Ah, the Tullio phenomenon.
Mhm.
It's a remarkable thing. It's an example of sound energy acoustic stimulation being pathologically translated into rotational vertigo. This happens when there's a defect in the bony labyrinth, creating what's called a third labyrinthine window.
The classic example being superior semicircular canal dehiscence.
Exactly.
Can you just break down the pathophysiology there? Why would sound cause vertigo only when there's a defect?
Sure. So normally sound energy goes into the cochlea through the oval window and then it exits through the round window. The semicircular canals, which handle balance, are supposed to be sealed bony structures that only respond to angular acceleration. However, if there's a thinning or an actual gap, a dehiscence in that superior canal, that little defect acts like a new pressure release point. So loud sounds or even pressure changes from coughing or straining create excessive movement in the inner ear fluid, the endolymph.
And that abnormal fluid movement is what stimulates the balance organ.
It directly stimulates the ampulla of that affected canal, causing vertigo and often a very specific nystagmus. It's a purely mechanical short circuit in the system.
That's a perfect example of what we're talking about, a detailed comparison. A mechanical problem causing a symptom we usually associate with, say, nerve inflammation.
Precisely. And we also check for things like visual vertigo, which is triggered by moving objects, like walking through a busy supermarket. This suggests an over-reliance on your visual system for balance, often after a peripheral vestibular injury.
And the final one is that very unique trigger, disembarking a boat.
Right, which, if it persists, suggests Maladie-Barkman syndrome.
So after we've established the chronology and the triggers, the history then moves to what you call the system check, comparing associated symptoms across visual, otological, neurological, and cardiovascular systems. What are the key visual differentiators we're looking for?
Well, first, you have to separate a primary visual problem from a vestibular one. If a patient reports double vision diplopia, that's an immediate red flag for something like a cranial nerve palsy. That's a neurological workup, separate from the vestibular one.
But within the vestibular system itself, how do we compare that feeling of rotatory vertigo against a more general visual instability?
So the true rotatory vertigo, the room spinning, is the primary sign. But the key functional comparison you're looking for is oscillopsia. That's the patient's complaint of blurred or wobbly vision, specifically during head movement.
And oscillopsia means the vestibular ocular reflex, the VOR, is failing.
It's failing to stabilize the gaze, exactly.
And where would we see a really profound, debilitating case of oscillopsia?
The most dramatic example is bilateral vestibular hypofunction. If both inner ears are knocked out, maybe from post-meningitis damage or ototoxicity from drugs like gentamicin, the patient loses the VOR on both sides.
So they can only see clearly when they're perfectly still.
Perfectly still. The minute they try to walk or run, their visual field just bounces uncontrollably. That lack of gaze stabilization it's severely limiting to their quality of life.
Moving on to the ear itself, the otological symptoms. You're looking for a specific cluster of symptoms here.
Yes. The presence of hearing loss, tinnitus, that's ringing and oral fullness, a feeling of pressure in the ear provides critical differentiation. If the hearing loss is fluctuating, it comes and goes, and it's associated with tinnitus. That's the classic triad for Meniere's disease.
And you compare that against other patterns of hearing loss.
Right. You compare that to, say, a sudden, permanent, single-sided hearing loss, which points more towards labyrinthitis. Or if the hearing loss is very slowly progressive and it's accompanied by a disproportionately severe sense of disequilibrium, you have to rule out an acoustic neuroma.
What about ear pain or discharge, otalgia or otorrhea?
Those point us towards middle or external ear pathology. An infection, maybe, or a more destructive issue like a cholesteatoma, which can actually erode into the inner ear and cause vertigo.
Okay, now the neurological symptoms. The presence of these fundamentally shifts the diagnosis, doesn't it? From peripheral in the inner ear to central in the brain.
Absolutely. The minute you have focal weakness, sensory changes, difficulty swallowing, any cranial nerve involvement, you have to rule out CNS pathology immediately. Stroke, a tumor, multiple sclerosis.
And the source material specifically mentions vestibular migraine here.
It does, because vestibular migraine is a CNS disorder, but it often presents with very specific non-vestibular symptoms like photophobia, light sensitivity, or phonophobia, and sometimes even temporary changes to smell or taste. That helps to differentiate it from a stroke mimic.
Finally, the cardiovascular comparisons. Unsteadiness from blood flow issues.
The common one is straightforward. Dizziness when you change posture, like going from lying down to standing up, signals postural hypotension. But there's a far more specific, though much rarer, vascular comparison tied to neck movement itself.
You're talking about rotational vertebral artery occlusion syndrome, RVAO.
Exactly. RVAO syndrome, sometimes it's called Bowhunter syndrome, is a fascinating mechanical comparison. The vertigo, which is often rotational, happens specifically with neck movements, flexion, extension, or turning the head to the opposite side.
So the head turn physically squeezes the blood supply.
It physically compresses a dominant vertebral artery, often against a little bone spur or a fibrous band in the cervical spine. This causes transient ischemia, a lack of blood flow to the brainstem and cerebellum, and that results in rotational vertigo.
And what's so critical about spotting this?
It's critical because, unlike most causes of vertigo, if you can confirm the diagnosis with vascular imaging, RVAO is one of the very few causes of recurrent vertigo that is potentially surgically curable. You can decompress the artery.
So we've completed this incredibly detailed history. Now we move into part 2, the physical examination. We're going from the patient's subjective report to objective, measurable findings, starting with the ear itself.
Right. The physical exam makes sure we don't miss any obvious pathology. Otoscopy is essential. We're looking at the eardrum for any signs of chronic problems, scarring, retractions, perforations, or that subtle white mass that might suggest a cholesteatoma. You have to consider the mechanical integrity of the whole system.
And central to that are the classic tuning fork tests, the comparison between Weber and Rins. Let's tackle the Weber test first because its logic can be a bit counterintuitive.
It can. The Weber test uses a 500 to 12 hertz fork placed on the center of the forehead. It's a lateralization test. You're comparing bone conduction between the two ears. If the sound is louder on one side, you have to figure out why.
And this is the key comparison. The sound lateralizing means it's either a conductive loss on that same side or a sensorineural loss on the opposite side. So why does a conductive problem make the sound seem louder in the bad ear?
This is the part that often trips people up. In a conductive loss, say the middle ear is full of fluid, the transmission of ambient noise from the outside world is blocked. So that masking effect is gone. Therefore, the bone-conducted vibration from the tuning fork, which bypasses that block, is perceived as louder in the blocked ear because there's less competing noise.
The ear is essentially quieted from the outside, which magnifies the internal signal.
Precisely. Conversely, if the sound is louder in the healthy ear, it's because the cochlea or the auditory nerve on the other side is damaged. It simply can't perceive the signal efficiently, so the sound is referred to the good ear.
And the Rins test confirms this by comparing air versus bone conduction in each ear individually.
Right, and the comparison here defines the type of loss. Normally, air conduction is louder than bone conduction. That's a positive RIN. If you find that, the patient either has normal hearing or a sensorineural loss. But if you find that bone conduction is louder than air conduction, a negative RIN, that confirms a conductive hearing loss.
Now, moving beyond sound, we assess mechanical integrity with pressure, the fistula test and Hennebert's sign. How do we distinguish these two?
The fistula test checks for a pathological connection between the middle ear and the inner ear. We apply pressure to the ear canal, either with a finger or a pneumatic otoscope. A positive test-inducing nystagmus or vertigo suggests a paralymph fistula.
So pressure causes fluid movement, which causes the nystagmus, and Hennebert's sign is sort of the exception to that rule.
It is. Hennebert's sign is defined as a positive fistula test without any evidence of middle ear pathology. This is a crucial comparative finding. If the eardrum is perfectly healthy but pressure still induces nystagmus, it suggests something inside is hypermobile or oversensitive to pressure.
What are the classic examples of that?
The two classic comparisons are congenital syphilis, which can cause a hypermobile States footplate, and some presentations of Meniere's disease, where you might have fibrous bands linking the balance organ to the stapes bone, making the whole system overly reactive to pressure.
Incredible detail. This really highlights how specific these signs need to be. Now we transition to the oculomotor system, the critical eye dance, where we're looking for nystagmus.
Nystagmus, that involuntary eye oscillation, gives us the most immediate, objective window into whether the problem is peripheral or central. We describe it by its fast phase direction, its waveform jerk or pendular, and whether the eyes are moving together.
And the ultimate high-yield comparison here is distinguishing peripheral from central nystagmus. This is the big one.
It is the big one. Peripheral nystagmus from a vestibular imbalance is typically horizontal or horizontal torsional. It has a unidirectional sawtooth-like waveform, but the defining characteristic is that it is suppressed by visual fixation.
Meaning if the patient stares at an object.
The nystagmus will diminish or even disappear. The brain uses visual input to override the faulty vestibular signal. That's why we use Frenzel lenses in the clinic to block fixation and bring out the true underlying nystagmus.
And central nystagmus, which indicates brainstem or cerebellar involvement.
Central nystagmus is far more alarming. If you see purely vertical nystagmus upbeating or downbeating or purely torsional nystagmus, that is almost certainly a central lesion. And crucially, central nystagmus is often not suppressed by visual fixation. It just keeps going.
We also use Alexander's law to grade and confirm a peripheral lesion. How does that work?
Alexander's law just states that peripheral nystagmus gets stronger when the patient gazes in the direction of the fast phase, so we can grade the severity.
What's a grade one?
Grade 1 is when you only see the nystagmus when the patient looks toward their healthy, non-affected ear.
Grade 2?
It's present when looking toward the healthy ear and when looking straight ahead in primary gaze.
And grade 3?
That's when it's present when looking in all directions of gaze. This systematic increase in severity helps confirm that the nystagmus is following the rules of a peripheral vestibular asymmetry.
Okay, moving beyond these involuntary movements, we assess the CNS components through voluntary eye movements, smooth pursuit, and saccades.
Right. Smooth pursuit. Just tracking a slowly moving target tests coordination between the visual and cerebellar systems. If pursuit is smooth and normal, that's a strong indicator against a central neurological disorder. If it's broken or saccadic, where the eyes jump to catch up, that suggests a problem in the cerebellum or brainstem.
And saccades, the quick, ballistic eye movements between two targets, test velocity and accuracy. Let's compare the accuracy failures.
Saccadic errors provide a fantastic map for CNS localization. We compare hypometria, which is undershooting, against hypermetria, which is overshooting. Hypometria, where the eyes fall short and need multiple corrective jumps, is often seen in pathology involving the basal ganglia or cortex.
And hypermetria.
Hypermetria is a classic finding. This is when the initial saccade goes past the target, requiring a corrective saccade in the opposite direction to fixate. This specific finding is highly suggestive of pathology in the anterior lobe of the cerebellum, where that fine motor control is integrated.
And the most classic, highly specific pathway lesion, internuclear ophthalmoplegia, or INO. We need to really unpack this mechanism.
INO is a complex failure that points to a lesion in the medial longitudinal fasciculus, or MLF. That's the key pathway linking the cranial nerve nuclei for coordinated side-to-side gaze. It presents as a failure of the eye on the side of the lesion to adduct to turn inward during lateral gaze.
And there's nystagmus in the other eye.
Exactly, nystagmus in the contralateral abducting eye.
Clinically, why is INO so highly suggestive of multiple sclerosis, especially in a younger person?
Because the MLF is a heavily myelinated tract, and MS is a demyelinating disease. It's a prime target. The failure of adduction happens because the signal to turn the eye inward gets blocked. But the diagnostic key, the vital comparison, is that convergence remains intact.
So why does convergence still work when the adduction for lateral gaze fails?
The neural pathways are separate. Adduction for lateral gaze is mediated through that MLF pathway, but convergence is a different supranuclear function that uses a separate pathway, bypassing the damaged MLF fibers. This difference failed adduction but maintained convergence is the defining feature that separates INO from a simple nerve palsy.
And the nystagmus of the abducting eye, why does that happen?
Well, the brain is sending this massive hyperactive signal trying to get the adduction to work. And since the eyes are yoked together, that powerful signal meant for the non-moving eye results in an over-innervation of the other eye, the abducting one, leading to this coarse hypermetric nystagmus.
That detailed look at eye movements gives us unparalleled precision. Now we move in part 3, assessing the vestibulo-ocular reflex, the VOR, and the positional maneuvers. This is where we really start to physically stress the balance system.
The VOR's job is simple. Keep your vision stable during head movement. We test this ability using a spectrum of speeds because the VOR is only truly irreplaceable at high velocity. At slower speeds, other systems can compensate.
Let's start with the slowest one, the slow doll's head maneuver.
This is just gently turning the patient's head side to side while they fixate on your nose. If the VOR is working, their eyes should stay locked on target. If it's failing, their eyes will drift with the head, and then you'll see a corrective catch-up saccade to bring their gaze back. It's a good gross test, but compensation can easily mask mild deficits.
Which brings us to the gold standard for unilateral lesions. The fast head thrust test, or head impulse test, developed by Halmigyi and Kurthois.
The HIT is crucial because it's a high-velocity, unpredictable head turn. We're talking around 200 degrees per second. That's fast enough that no other system, not the neck, not the visual system, can compensate for a VOR deficit.
So how does a positive test look?
If you have a patient with a right-sided vestibular loss, you perform a quick head turn to the right. Since their right semicircular canal can't generate the right signal, their eyes will be dragged off target for a moment before you see one or more very quick catch-up saccades bringing their gaze back to your nose. It confirms a peripheral lesion on the side of the head turn.
Now, the data on this is complex. It has high specificity but maybe lower sensitivity. Why is this data comparison so important for how we interpret the test?
It forces us to distinguish between an acute injury and a chronic compensated one. If the test is positive, you can be highly confident there's a significant lesion. But if it's negative, you can't rule out a deficit, especially if the patient has had months to centrally compensate. The brain has essentially learned to mask the problem, so we have to treat a negative HIT with suspicion in a chronic setting.
This inherent limitation, the body hiding the deficit, is exactly why we need a whole battery of tests. And in an acute vertigo attack, the head impulse test is the first letter of the most critical diagnostic tool in the emergency room, HINTS.
The HINTS exam head impulse, nystagmus, test of skew, is the single most powerful tool for differentiating a peripheral acute vestibular syndrome, like neuronitis, from a central one, like a stroke, in those first 48 hours. It's actually been shown to be superior to an early MRI in ruling out stroke.
Okay, let's break down HINTS as 3 sequential comparisons.
First, H for head impulse. If the HIT is positive, meaning you see catch-up saccades, the VOR is broken. A broken VOR almost always means the lesion is peripheral, the inner ear is damaged. But if the HIT is negative, the VOR is intact, which means the severe vertigo must be coming from a central source, the brainstem or cerebellum.
Second, N for nystagmus. We compare the characteristics.
In a peripheral case, the nystagmus will be unidirectional, always beating in one direction, and horizontal. In a central case, the nystagmus might change direction with days, or it might be vertical or torsional. That direction-changing nystagmus is a huge escheral red flag.
And third, TS for test askew. This looks for ocular misalignment.
Right, a vertical misalignment. You have the patient cover one eye, then uncover it, and you watch for a corrective vertical movement. Any vertical misalignment or skew deviation is strongly suggestive of a brainstem lesion. It points strongly to a central cause.
So if a patient has a negative HIT, direction-changing nystagmus, and skew deviation, that's highly concerning. But a positive HIT, unidirectional nystagmus, and no skew, that's a safe peripheral diagnosis. The comparison is that stark.
In an acute presentation, it is that stark. If all 3 HINTS findings point towards peripheral, the likelihood of a stroke is incredibly low. But if even one component is central, especially that negative HIT, you have to assume it's a stroke until proven otherwise.
We also have the headshake test. How does its utility compare to the HIT?
The headshake test is really testing for a chronic, uncompensated asymmetry. You shake the head for 20 seconds, and if nystagmus appears when they open their eyes, it suggests a deficit. But as the data confirms, its sensitivity is pretty low, sometimes down to 27%.
So we should only see it as supportive evidence.
Exactly. It's useful if it's positive, but a negative test is basically meaningless, especially when the HIT is so much better for acute lesions.
And finally, before we get to BPPV, we have the functional VOR test. Dynamic visual acuity.
This is a great functional comparison. The patient reads a Snellen eye chart while still, and then again while you're gently shaking their head. If their reading ability drops by 3 lines or more, that strongly correlates with a peripheral vestibular deficit. They just can't keep their vision clear during motion.
Okay, now let's move to the most common cause of all of this. BPPV, diagnosed with positional maneuvers, specifically the Dix-Hallpike test.
The Dix-Hallpike is indispensable. We move the patient quickly from sitting to lying down with their head hanging back and turned 45 degrees to the side we're testing.
And for classic posterior canal BPPV, which is most cases, there are 3 non-negotiable temporal characteristics we're looking for.
Yes, the 3 key comparisons for BPPV are latency, a delay of a few seconds before the nystagmus starts, adaptation, where the vertigo and nystagmus fade away within a minute or two as the crystals settle, and fatigability, the response gets weaker with repeated testing. If you have nystagmus that's immediate, sustained, and doesn't fatigue, that's almost certainly central.
And the direction of the nystagmus for the posterior canal.
It's torsional, a twisting motion, and geotropic, which means downbeating towards the floor. That very specific combination is what clinches the diagnosis.
And we have to compare this against the much rarer superior canal BPPV.
That's a challenge because most vertical nystagmus is central, but superior canal BPPV usually provokes a vertical downbeating nystagmus, often triggered by placing the head as low as possible.
And then there's the elusive lateral or horizontal canal BPPV, which needs the supine head roll test.
This one is often missed by the Dix-Hallpike. The supine head roll involves rotating the patient's head 90 degrees to each side while they're lying flat. The nystagmus you see is purely horizontal, and it's often very intense.
But within that horizontal canal, you have two subtypes, geotropic versus ageotropic. This is where the intensity comparison is critical.
It's absolutely critical for figuring out where the debris is. Geotropic nystagmus beats toward the ground, and the key is that the intensity is stronger when you turn the patient's head toward the affected ear. This indicates canalophysis, the debris is free-floating in the canal.
And the ageotropic type.
That's the opposite. The nystagmus beats away from the earth. This pattern suggests cupulolithiasis, meaning the debris is actually stuck to the cupula, the motion sensor itself. This mechanical comparison, free-floating versus stuck, is essential because it determines which repositioning maneuver you need to use to treat it.
And the final word of caution during these maneuvers.
Persistent, non-fatiguing, purely vertical or direction-changing nystagmus during any positional testing means the problem is central, and it needs immediate investigation.
We've now completed that detailed VOR and positional testing. So for part 4, we have the neurological and postural assessments that bring in the lower limbs and higher coordination centers. The cerebellum is our focus.
Right. The cerebellum is the master coordinator of movement. Damage there results in ataxia, uncoordinated, clumsy movement. We're comparing the precision of movement against established norms.
What are the key comparative tests for cerebellar function?
We check for dysmetria with the finger-to-nose pointing test. Someone with cerebellar involvement will consistently undershoot or overshoot the target. This often suggests a problem in the lateral cerebellar hemispheres.
And the inability to perform rapid alternating movements.
That's called dysteiodoshokinesis. Asking the patient to rapidly clap their hands or tap their foot reveals slow, clumsy, or asymmetrical movements. Again, this points to lateral cerebellar pathology.
How does a cerebellar gait contrast with a peripheral vestibular gait?
A cerebellar ataxic gait is wide-based, staggering, and often chaotic. It reflects a global coordination failure. We contrast that with a gait from a peripheral vestibular problem, which tends to be a consistent veering or listing to one side, the side of the damaged labyrinth. The comparison is the consistency of the deviation versus unpredictable staggering.
That brings us to the vestibulospinal tract tests, which assess postural control by taking away sensory inputs. Romberg's test is the classic.
Romberg's test removes visual input. The patient stands with their feet together, first with eyes open, then closed. If they only sway or fall when their eyes are closed, that's a positive Romberg.
And what does a positive Romberg tell us?
It means the patient is relying heavily on their vision to compensate for a deficit in either proprioception or the vestibulospinal tract. Patients with a unilateral peripheral lesion will often sway toward the side of the lesion when their eyes are closed.
And we contrast this with the stepping test, or Fukuda's test.
The stepping test tries to remove both vision and proprioception by having the patient march on the spot for 50 steps with their eyes closed. A rotation of more than 45 degrees to one side is considered positive, suggesting a peripheral hypofunction on that side.
But the source material flags a serious caution about this test's reliability.
And this is a vital caveat for any clinician. The data shows the stepping test has poor sensitivity around 50% and only mediocre specificity. This means a normal test often fails to rule out a peripheral deficit, especially in a compensated patient. We just can't rely on a negative stepping test to clear someone if our clinical suspicion is high.
And finally, we wrap up the physical exam with a mandatory cardiovascular check.
Absolutely essential. We have to screen for postural hypotension by taking blood pressure lying and standing, and we have to listen for carotid brutes, which could suggest vascular issues contributing to brainstem insufficiency.
So we've covered this entire comprehensive battery. Looking back, what is the final synthesis, the big takeaway on why this systematic comparison is so necessary?
The final synthesis is that dizziness is almost never diagnosed by a single test. The power is in the comparative evidence. We compare the results of the VOR tests, the characteristics of the nystagmus, the accuracy of coordination, the response to positional changes. You have to complete the entire battery, even if something like the Dix-Hallpike seems conclusive, to make sure that subtle, associated central pathologies are never, ever missed.
This has been a true deep dive into the systematic nature of this clinical assessment. We moved from that critical subjective distinction of true rotatory vertigo all the way to the objective precision of the HINTS exam in an emergency.
And we've seen just how specific these clinical signs can be, from recognizing the hypermetric saccades and internuclear ophthalmoplegia, which points right to an MLF lesion, to differentiating geotropic and agiotropic nystagmus, which tells you exactly where the debris is in the canal.
We also wrestled with the limitations, didn't we? Noting that the body's remarkable ability to compensate can often mask these peripheral deficits in chronic patients, making tests like the head shake and even the head thrust unreliable when they're negative.
And that leads directly to our final provocative thought for you, the listener. We established that the VOR can only be truly tested at high velocity because at lower speeds the brain recruits other systems to compensate. Now, if the brain is so adept at masking these deficits, and the gold standard HINTS exam is designed primarily for the acute setting, what are the diagnostic implications for that huge population of patients suffering from chronic, compensated, low-grade dizziness? Does this reliance on acute phase tests suggest that we are currently underdiagnosing or maybe mismanaging those subtle long-term peripheral deficits simply because the body is too good at hiding the evidence?
A question that really pushes us to consider how much we might need technology to see what the body so successfully hides from our clinical acumen. Thank you for joining us on this deep dive.